Well, it's great to see everyone. I'll just quickly introduce myself. I'm Eva Raphael. I'm at UCSF, and I'm here to moderate this session, which Dr. Giulia Lane has graciously accepted to give. So Dr. Lane is an assistant professor in the Department of Urology at the University of Michigan, currently a K-12 scholar in the KUroEpi Institutional Research Career Development Program, and she will discuss her research on patient and physician perspective of overactive bladder.
I'm really glad to be here. I spoke at this conference in 2021, and it was really nice to revisit what I talked about then and what I'm talking about now and sort of see how much sort of progress that I feel like I've made trying to understand decision-making in overactive bladder. Part of my talk is also going to be based on a conversation I had with Chris about sort of like the pearls and pitfalls of clinical-based research and health services research and some things that I've learned or like workarounds because it does seem to take a really long time to do patient-based research. The only disclosure I have is that I am a K-12 scholar and my mentors are Dr. Clemens and Dr. Sarma, and I'm very thankful for that. I wanted to spend a minute just to get to know everyone in the audience and what kind of research that you guys are doing or your interests. So I wanted to ask everyone to use one word to type your main methodology that you use, like, whether it's basic science, translational, whatever it is that you feel like would describe the research that you are doing. So it looks like we have sort of a span of people ranging from basic to bioinformatics to clinical. There's some more coming in. And IDVK, yeah. So just to give a little bit of background, I started, like the first research I ever did was as an undergrad in 2010, and that was like neuroscience with like growing cerebellar cells. And I was like counting dead or alive cells, and it was like very bench-based research. And then like fast forward to residency, I got into more quantitative and like your more clinical, traditional clinical, looking at like chart review. And recently, as part of this K-12 project, I've delved into doing mixed methods and qualitative research. And that's, I think, a methodology that that's growing and people are less familiar with. So I wanted to spend a little bit of time as part of this talk to talk about that. So we all know that overactive bladder is prevalent, that it's very bothersome to people that are affected by it, that has a huge burden on those suffering from overactive bladder, both by limiting their lifestyle and also by adding a lot of anxiety, stress, stigma to their lives. Fortunately, we have for overactive bladder some nice pathways to care. So we know that we have first-line therapies, second-line therapies, and third-line therapies, which we're very much familiar with as the progression of medication or of treatment for overactive bladder. One of the things that I think less people are familiar with is that I think overactive bladder is what's called a preference-sensitive condition. So this is a condition where there's multiple treatment options, where there's similar outcomes between the options at each tier. And really the decision to do any treatment is driven by patient preferences. And that's important because in overactive bladder, patients must face many decisions. So this is the SUFU roadmap for overactive bladder. And you can see there's a lot of points in the road where patients are faced with decisions. And that can be really hard to navigate for a lot of patients. And I think sometimes it can, without guidance, it can cause them to fall off the road or pull over and stop getting their overactive bladder treated. So how can we facilitate decision-making in overactive bladder? And that is my big question. But before I could answer that question, I had to talk about my next question, which is what even informs decision-making for overactive bladder? So how are people making these decisions? And to answer that question, I really had to figure out a different methodology because my background in health services and more like quantitative methods isn't well geared to answer those questions. And so luckily at the University of Michigan, we have a mixed methods research center. And within our department, Daniela Whitman is a PhD and a social worker that is an expert in mixed methods research. And she put me in touch with Melissa de Jonquière, who's also a mixed methods researcher. And I was able to get some mentorship to devise a strategy to answer that question: is how are people making decisions for overactive bladder care? And basically, mixed methods research pairs quantitative and qualitative data. And I think a really big point of it is that there has to be integration between those two. So the two, qualitative and the quantitative, both inform sort of each other and inform the final results of the study. And if you're interested in this kind of methodology or learning more, these are some resources that I used that I thought were really good to sort of as a springboard to get started. And I'm happy to share more information on sort of how I learned a little bit more about this. So I think all studies start with a conceptual model, and the conceptual model that informed this was the fact that decision making is sort of nested in different, it's not sort of done in a silo. So we have patient factors, which I use the health belief model. So patients are cued to action by different beliefs about their health, and for example, like their potential benefits or risks of an intervention. But those patient actions are really not in a silo. Clinicians can influence patients by providing cues to action, and clinicians are influenced by their training and background, by their patterns of managing care and their beliefs about the syndrome. And moreover, I think both patients and clinicians are very heavily influenced in overactive care by policy factors, which is like clinical practice guidelines and payment models. And that policy piece really sort of is near and dear to me as a health services researcher, which is like the ultimate goal is how can our research change the current policies that might be barriers to care. For this research, though, I'll focus on the big blue arrows, which are the patients and the clinicians. So the K-12 project that I'm now in the second year of and sort of doing AIM 2 right now, started with a qualitative study where we looked at patient and clinicians and did a series of semi-structured interviews and also surveys. And then the next phase of that will be or is quantitative. So that is data collection that I'll go into a little bit more, traditional like regression prediction models based on or informed by the qualitative studies. And this is what we call, so there's different types of mixed methods research, and the way that they're named is sort of how you integrate the data that you're getting. So this is an exploratory sequential, which means that the qualitative piece was really to explore and develop new themes, and then apply those in sequential methods to inform the quantitative research. And there's many different ways of sort of integrating the qualitative and the quantitative, depending on what you're trying to discover out of your own projects. So this ended up being, the AIM-1 ended up sort of being its own like sort of nested mixed method research study. So, and I was really fortunate to have two like very stellar medical students, which I'm happy to say are both applying to urology this year, helping me with this. And the way we did this is we did patient interviews and surveys and physician interviews and surveys, and then we separately coded and transcribed the patient and the physician cohorts. And then we did thematic analysis of what we found out of those cohorts. And then we sort of brought it together to compare and contrast between the patients and the physicians. And when we're thinking about like what is driving decision-making for overactive bladder, and also when we're thinking about qualitative research, I think it's pretty important to know what people, like what exactly the participants were asked, because how you ask things and how you frame things can really change the responses you're getting. So for this, for the patient interview guide, we asked patients, thinking back to the treatments, what kind of qualities were important to you? and what made you try a certain treatment. And then for the physician, we gave more scenarios, like imagine a patient with this condition. What are your thoughts on offering therapies? What's most important to you? Why is that? So very open-ended, trying to get as much information as we could. So for the patients, we ended up doing about 21 interviews. And this goes into I'll talk about this a little later, but in order to get through the IRB in a reasonable amount of time, all of the interviews and the surveys were completely anonymous. And so we weren't able to link any of the survey data to an individual participant that did an interview. And so there were people that dropped out. And so that's why the numbers are a little bit different. But overall, these were females. Many of them had tried first, second, and third line therapy. And we sampled, it's about 50% of third line therapy because that was what we were sampling for. And then from the physician side, mostly female physicians, most were urologists, though we did try to get gynecology representation. Everyone we surveyed were subspecialists. So that is maybe a limitation of the applicability of this. They had been in practice, a fair amount of time and definitely having a heavy load of people with OAB. So lots of experience in this. And what we found when we were asking about what influenced patients' decision is that patients are really, not surprisingly, driven by efficacy. So they just want something that works. They want to know how well it's going to work for them. The expense of the medication or the treatment is really important. Lots of these patients are older on fixed budgets. Risks were like the third most common. There were some also like new themes that we found that we weren't expecting. So there's this theme of people wanting to avoid medication. And then also looking for alongside that, more holistic natural approaches, which was not something we had found before. And there's also this thought of trying to cure their OAB, which to me is an opportunity for education about, OAB being a syndrome that we don't really, I don't really consider it something that ever has a cure that ends. It sort of maybe gets better or worse, but it's a lifelong chronic syndrome. And then these trade-offs of, people not really wanting to compromise on their lifestyle. And so that's something we definitely see. So in that mixed methods fashion, we quantitatively tabulated what was cited most by patients, and efficacy was definitely 80% of patients said efficacy was important to them. And then we'll talk about the clinician side in a second, but you can see how the patients are in the dark blue, so they're valuing efficacy while the clinicians are really valuing safety and avoiding risks. So on the clinician side, again, really risks are at the top of the line for clinicians. So they want to know how risky something will be. They look at patients' age and comorbidities to even offer certain therapies. They have sort of clinicians are doing an internal calculation on which therapy they think will work best with a patient. And to me, someone who's interested in prediction, this is really interesting because we don't really know if these internal models are valid or applicable to everyone. I was surprised to see that actually several physicians did value patient preference. And I think that is something that we usually downplay, that physicians aren't doing as much shared decision making, but really in overactive bladder, I think most of the physicians said that the patient preference was really important. And then expense was the last factor, so that they cited. And it's really interesting to me that cost is sort of dichotomous. So it matters for medications, but it doesn't matter once you're into advanced therapies because of how our insurance policies are structured. And again, this sort of just puts the patients in the dark blue and the clinicians in the light blue, and it says that that each of these groups are saying the same things. They're just weighing them differently. And those differences might lead to some misalignment or misunderstanding or expectations that are not met or not clear between the two parties. So for me, the key takeaway again is that patients really prioritize efficacy. There's these subsets that want to avoid specific types of treatments, while clinicians prioritize reducing risks. And they sort of have this intuition about steering patients or what therapy is best for patients, which might not really align with shared decision making if therapies aren't being offered to patients, depending on these sort of internal calculations. To me, like doing all of these interviews, first it was like super rich. This is just like a small fraction of what we found talking to people about their experiences. But also it showed me that shared decision making is actually is a good paradigm for this condition. And not that we necessarily need to make the priorities of the patients and the physicians the same, but I think it definitely brings to like the forefront that clinicians should be clear about what they're prioritizing, and sort of maybe using verbiage like, you know, my priority is your safety, and that's why I think X, Y, and Z would, you know, and then patients have an opportunity to say, okay, I respect that, but I still want to try, whatever therapy. So in the next portion of this is the quantitative portion, and we have just sort of gotten started with this. And the way that we're doing this is, so there's a lot of potential data sets for overactive bladder, but I think one of the richest one is the electronic medical record. And so as part of this K-12 grant, I was able to work with our electronic health record data management people to basically make a custom database that scraped all the data about anyone with the diagnosis of overactive bladder, including their patient-reported outcomes, which have been for us recorded mostly electronically for at least the past 5 years. And so this data set is like a 10-year data set of anyone with overactive bladder in our institution. And the thought is that if we can take this record, this health database, and clean it into a usable way, then we can use that to make models looking at outcomes. And then we can take those models that look at outcomes and then use them to make nomograms or prediction models to try to help decide what treatment might be best for a patient based on their characteristics. So in essence, taking those calculations that clinicians are doing in their mind and trying to put them on paper and validate them. So for this study, we tried to start with the sort of most straightforward cohort creation. So we took men and women with OAB who had sacral neuromodulation and had a successful implant, and we looked at the outcomes of either needing more therapies after their stage 2, so people who had an InterStim, but then, a sacral neuromodulation device, and then down the line needed more, and people who had an explant. What we found was that, first of all, we had a pretty rich data set for this condition with over 300 people. Of those, about 80% had a successful implant, which is just in line with the RCT data. And we found that of the people who had a stage 2 implant, about 63% didn't have any other OAB treatments, and we had a minimum follow-up of 1 year for these people to be included, whereas 40% did need an additional treatment after their advanced therapy. And of both cohorts, there was a subset of people who had their device explanted for various reasons. Of course, as you can imagine, the explant rate in the people who needed more therapy was higher than in those who didn't. And we looked at some time to event curves, and we found that about 20% of people, 17%, needed an explant, and that was about 8 years after their device was implanted. And these were extractions without a replacement, which the 8-year mark is could be having to do with battery life. And then again, about 40% of people who had a device placed needed an additional treatment. And that was about by year 4. And so to me, we're still working with this data set to try and predict who who those people are, what's happening to them. But to me, the main takeaway of this very small um, question was that one, we can leverage the medical record to explore these outcomes. That already it's given me some information about how to counsel my patients, especially using our own data. That there's a pretty high likelihood they might need something more, which reinforces OAB as a chronic condition. And then I think it also sort of spurs more questions. Why is more therapy required? Is this a disease progression, or is it something to do with neuromodulation and the way that we're delivering this treatment? And again, the next steps for this for me is to try to predict who is at risk for needing more therapy, so that we can appropriately counsel people up front. So for me, the next steps is I've asked for more training time through a K23. And the goal is to continue the work that I'm doing and then embed this into a decision aid that would include a first step would be education and a symptom assessment, or sorry, it's a symptom assessment at first. The second step is education about overactive bladder. Third is values clarification. So that gets into what is the patient valuing? And finally, using those prediction models in that tool to give people an estimate of where they might stand with different therapies. Not in a prescriptive way, but just to give them accurate, hopefully accurate estimates of what they can expect as far as benefits and potential harms. And as part of that K23 application, I'm hoping to do a small pilot of this. So to explore the use of this in this decision aid in a clinical intervention compared to a control, which would be like a static decision aid, and to see whether it's first of all feasible to embed this into a clinic and hopefully explore some of the impact on decisional quality or treatment decisions for overactive bladder. And we have a little bit more time. So I wanted to sort of talk about this conversation I had with Chris about trying to do clinical work and things that we balance. And I think for me as a health services research, we always talk about data sets and ideally we would be able to collect prospective data so we could ask and collect exactly what we needed. But even for very simple prospective data collections, it's at least a year from the time of concept to data collection due to regulatory barriers. You can sometimes get around this, for example, or not get around, but sort of mitigate some of that by collecting less PHI. So for the qualitative data to really get that going, we realized we didn't really need any PHI. It could be done totally anonymously. And that was really helpful to get the study going. But on the back end, we can't link our quantitative and qualitative data. And that is a limitation. And so really trying to see whether anyone else has already collected the data that we need prospectively to answer a question. And again, for the retrospective data, while the IRB is simpler, we don't really have the data that we need. And I'm facing with the electronic health data, the data is very messy and it's requiring a lot of cleaning. We're doing a lot of quality checks to basically go into the charts and make sure what we think we are getting with codes is actually what is represented in the chart. And so I'm always looking around for any data sets that captures what I need to answer my question. But I don't think there is a perfect data set out there. Everything comes with limitations.